and deaths associated with opioids. My name is Dr. Brent Martin. I am the DentaQuest Dental Director for Tennessee, based here in Middle Tennessee. Today I have three objectives for our time together. First, to document that there is a serious opioid problem. Second, to clarify that dental prescribers are significantly contributory and partially responsible for this national and local problem. And third, I will present irrefutable evidence and documentation that opioids are less effective than other non-opioid choices, and opioids should rarely, if ever, be the first choice for acute pain management. I'm going to begin with a Charles Dickens quote. It was the best of times, it was the worst of times. It was the age of wisdom, it was the age of foolishness. It was the epoch of belief, and it was the epoch of incredulity. It was a season of light, it was a season of darkness. It was the spring of hope, and it was the winter of despair. That's Dickens from The Tale of Two Cities. I begin with this quote because we know so much more now than we have ever known about pharmacology, about the anatomy of nerve pathways, and how pain meds work in remote sites and local sites. So clearly, in some ways, these are the best of times. However, I'm not sure that these data following will make you aware that these are also the worst of times in addiction, abuse, and deaths related to opioids. This picture shows us that since 1999, sales of prescription opioids have quadrupled. Now, you can do the arithmetic just like I can, but in less than 10 years, we have 400% more opioids, and certainly the population has not quadrupled by 400% in that period of time. More than 11 million people abused opioid prescriptions in 2016. Just think about that. This slide shows us data confirming that these are the worst of times. The important takeaway is the slope on the line and the clear relationship between all drug overdose deaths and opioids. It is critical that we rethink and permanently change our prescribing of opioid meds for all patients who might need relief of acute pain post-op. The next 6 slides are developed from articles and data in the most recent JADA, April of 18. So very, very current information. I will start with the first article, which is opioid prescribing practices from 2010 through 2015 among dentists in the United States. And you will see after these slides that our current practices are a lot of the problem. This table provides data of opioid prescribing patterns by age and by year of prescribing. The table on the prior slide has a little bit too much data to understand easily. The trend is what I really want you to understand. The slope on this line is very troubling. Now, while the previous slides has great a little information, here is the concerning takeaway. Note these are children under age 11. I asked the head of the pedodontics program in a very well-known program, what were the indications for opioids in children under the age of 10? His immediate response was none. I would repeat, none. Noting here that there's an increase of 31.5% between 2012 and 2015 in children under age 11. Even more concerning is this slide, noting a 66% increase in 5 years in these children between the years of 2012 and 2015. How shameful. The JADA article here says that dentists wrote 6.4% of all opioids. Another citation later in my presentation from CDC opines that dentists write over 11% of the opioids. The conclusions are very, very troubling and cause for concern. Let me just share two bullet points. The results. The opioid prescription rate per 1,000 dental patients increased from 130.58 in 2010 to 147.44 in 2015. Approximately 68% of all opioids were prescribed during surgical visits and approximately 31% during non-surgical visits. During the non-surgical visits where dentists prescribed an opioid, most of the procedures were restorative. What in the world are we doing writing for opioids when there are far more effective meds for restorative procedures? Here I am referencing the Golubic and Moore article. They are admitted experts in the field, and this makes clear their findings and their position. The statement says, currently opioids are routinely prescribed in cases that could often be appropriately managed with NSAIDs and are also prescribed in excess quantities in many dental prescriptions. I share with you the citations if you want to do the research. We then go to an article noting the significant difference between prescribed and used. The data here tells us the mean opioid prescribed without localized osteitis, also known as a dry socket, again without, was 28. And the number taken by the patient was 13. So this confirms a serious problem that was on the prior slide, the dramatic difference between the number prescribed and the number consumed after third molar surgeries. In both cases, only about half of what was prescribed was actually taken, leaving half of the meds available for diversion to other sources. Here I bring in a table from CDE World Continuing Education, and it talks about the increasing levels of pain, mild pain to moderately severe pain to severe pain. You can read this at your leisure. However, I would point out that these recommendations show that with the continuum of increasing severity of pain and the medications that are deemed appropriate, opioids are only recommended if NSAIDs were not effective. Focus on the word only where I draw the arrow. Well, you might be thinking the problems in other areas, nationwide and other areas, but not so much here. The term that I want you to think of is ris ipsa loquitur. The evidence speaks for itself. Here in Tennessee, we have a very serious problem. In 2016, Tennessee was the third highest prescriber of opioids in the United States. I bring in the CDC data and show you the number and the age-adjusted rates of overdose deaths. Focus here again, deaths. And in Tennessee, our death rate went up by 7.7% in 1 year, secondary to opioids. This particular slide is a very informative slide. We as dentists were not trained in the process of this way of thinking. NNT, the acronym for number needed to treat. However, the findings are very important for appropriate management for our patients, noting that the bottom one, codeine, is the very least effective opioid, even when opioids are used, when viewed as the number of pills needed to attain 50% of relief of the pain. And the most effective, the smallest number of NNT, the top 4 meds, had no opioids whatsoever. Here is an ADA publication on dental guidelines for prescribing from 2017. And the CDC also says the scientific evidence indicates that routine opioid prescribing by dentists, here's the slide I referenced earlier, is estimated to be 11% of the overall total annual prescriptions, indicating that approximately 1,500 deaths may be attributed to unused opioids. How sad. Back to the CDE article, one of theirs, maybe the most important article of all. I would ask you to focus on the statement, time to change clinical practices in response to evidence and misperceptions. There is a better solution. Despite evidence that non-opioids are often sufficient to manage pain and have actually been shown to perform with greater efficacy than opioids in most clinical trials, The dentist may prescribe opioids, quote, simply because it is the treatment which he or she has the most clinical experience and is most comfortable. Again, referencing the Gulliver article. So, a little rehash here, but the statement is, and it is worth it. The takeaway is the authors found that ibuprofen APAP combination provided greater relief of pain than did ibuprofen or APAP alone after third molar extraction. My data that I'm sharing, I point out here again, is from April of the JADA. Opioid medication and medication combinations are not among the most effective or long-lasting of options available for relief of acute dental pain. In addition, opioid medication and medication combinations are associated with higher risks and rates of adverse selection. Benefits and harms associated with analgesic medications. When comparing the efficacy of non-steroidal anti-inflammatory medications with opioids in relation to the magnitude of pain relief, the combination of 400 milligrams of ibuprofen plus 1,000 milligrams of acetaminophen was found to be superior to any, I will repeat the word any, opioid-containing medication study. Therefore, we know for sure you should never start with an opioid as the initial treatment for acute pain management. This is a restatement, but it merits restating. Among the population of dental patients with private insurance, opioid prescribing rates in the United States increased slightly. The largest increase was among 11 to 18-year-olds, children, and almost one-third of the opioids written by dentists were associated with non-surgical dental visits. We've got to stop, we've got to change. I do bring in here a slide from a very recent product, probably I saw it about 6-8 weeks ago, and it is intranasal, it is an NSAID, and it provides significant pain relief at the, quote, opioid level. So I would encourage you to look this up, Sprix, S-P-R-I-X, and see if there's any place for this to be used in your particular practice. Now we're going to spend a few minutes on the PMPD, Prescription Monitoring Program data. Very important. These examples are in the American Dental Association journal, the JADA, but they are from Massachusetts. A 55-year-old woman with a history of TMJ, joint pain, and surgery, and prescription drug misuse was evaluated for recurrence of facial pain. Her data showed that in the past year she had received 151 prescriptions, of which 97 were opioids, 20 benzos, and 19 analgesics. They have been written by 53 prescribers, 10 of which were recognized as dentists, and she had had them filled at 27 pharmacies. She was registered under 2 different names and had 2 addresses. A different patient, a 33-year-old healthcare professional with jaw pain, moved from a neighboring state. The dentist was suspicious of her symptoms and her stated needs for opioids. In the past 6 months, the patient had had 20 prescriptions, 16 opioids, and 2 benzos, written by 18 prescribers, 15 of which were dentists practicing within a few miles of one another in the metropolitan area. These prescriptions filled at 10 pharmacies. A check of the data from the neighboring state demonstrated the same pattern of dentist shopping. We here in Tennessee have the database, the controlled providing database, and while we know and we are obligated to check it, only about 40% of the physicians and the dentists are using the prescription monitoring data program in Tennessee, and we will strongly encourage you to avoid these kinds of shopping to begin using that. CDC guidelines, control and prevention. Long-term opioid use, long-term now we're talking about addiction, often begins with the treatment of acute pain. When opioids are prescribed for acute pain, clinicians should prescribe the lowest effective dose of immediate release opioids and should prescribe no greater quantity than needed for the expected duration of pain severe enough to require an opioid. 3 days or less will often be sufficient. More than 7 days will rarely, if ever, be needed. It will not be easy. Frankly, I expect it will be difficult and will take a significant amount of time. But it is past time to start. We must stop what we have been doing. I'll close by saying that I sincerely hope that you as a professional have had a permanent behavioral and paradigm shift. In my career, I have seen amazing progress in oral health and frequently appropriate dialogue about many issues, some of which have been controversial, such as amalgam versus composite restorations, such as capitation payments versus fee-for-service, such as extractions of viable teeth versus endodontic therapy, such as expanded duties of our team members versus denial of expanded duties. This is not controversial. The crisis of opioids requires only one thing as professional, just a sorry. That is the Latin term for do the right thing, in this case, for our patients. Thank you for joining us this morning.